Hi, welcome to my Eye to Eye podcast, and I'm happy to invite my next guest, Professor Dr. Jorge Alió. Today we're going to talk about the new revolutionary cell therapy for keratoconus patients. Enjoy the episode. Professor Dr. Jorge Alió.
Good morning. How are you today? Fine?
I'm good, and you? Yes.
Fine. Happy to be today. This is a new way to communicate.
So first of all, I wanted to tell you that these three articles, especially three articles which I read about stem cells, they are really amazing. And I realized that once you read the 2021, and it's better to read from previous one because it's like you were telling a story, and it was just so great and so clear. Just wanted to tell you that.
Well, I think it's the future of corneal surgery. You are at the beginning of a change that will lead to a completely new and better, let's say, surgery as well.
Absolutely. Before we start, just one question. What was the kick for you that you decided to go for cell therapy, especially for keratoconus patients?
Well, thank you very much. I think that this topic, corneal regeneration, is indeed the beginning of a new story, which is the beginning of a new way to operate the cornea. You know, the reasons that led me to start this investigation about 14 years ago was my clear perspective that my results in corneal graft, even that were aligned with what is the state of the art, were not optimal. You know, we take just virgin and good cases, we know that reaction and problems happen in about 18-20% of the cases maximum. But if you are dealing with high-risk cases in corneal graft surgery, especially penetrating keratoplasty, your risk is over 50%. And if you analyze your outcomes after 5 years, you realize that many patients have not been successful, not only because of the corneal graft biological problems, rejection especially, but also because comorbidities, especially glaucoma, makes a very negative impact, and also because ocular surface matters. So it's not only about the cornea, it's about the environment of the cornea. With this in mind, we started thinking in how to implement the process of corneal substitution, and not by graft. And this is when the idea of regenerating the corneal stroma appeared, because the studies on corneal surface have been quite a lot. Still, this technique is not completely successful, but at least have been a progress. The endothelium is still a problem, but we have the studies of Japan about endothelial cell regeneration, and since that we shall have this issue solved more or less in the next 10 years. But corneal stroma was not affected by any modern approach, and is the 99% of the corneal content. So even if we have a nice endothelium, nice ocular surface without the stroma, you cannot get the cornea. And it's when we started thinking about regenerating the cornea with the stem cells of human origin. And the first step was to know whether the corneas implanted in an eye, in this case, animal eyes, rabbit eyes, could be possible to survive and to produce collagen. The experience that we had consisted in implanted human mesenchymal stem cells of adipose origin in the corneal stroma of the rabbit. And we could demonstrate by immunohistochemistry that the cells were the human ones that we implanted, and that they survived, and not only that, they produced human collagen in the rabbit cornea. This was the pristine finding, and unique because never before this has been described, and indeed demonstrated that the cells implanted in such a model were able not only to survive but to produce human collagen in a rabbit cornea that was clearly produced by these cells and not by the host cells that could be stimulated by the implanted cells. With this in mind, we start investigating the carrier of such cells, because cells cannot be by themselves being able to regenerate the whole cornea. They need to have a scaffold, especially thin corneas or very diseased corneas needs to have a carrier. And then among the different carriers that we investigated, we could demonstrate that the best one was the acellular human cornea. So human cornea, and later on, any type of cornea, especially from the porcine origin, from the pig, could be the substrate, could be the carrier of the cells. And then we started these experimental studies in the animal, and we demonstrated that this was feasible. This is the starting point of the clinical study, in which we use, following many permissions, and regulations that this regard in this very new topic are very difficult to get. But finally, we got the permission to make this study in Lebanon, in which we use the keratoconus as the model. Why keratoconus? Because it's the most common and frequent corneal dystrophy, because it leads to corneal graft surgery frequently, and we took extreme cases that were indicated for corneal graft using this as a comparative indication. And then we randomized the cases among cases in which we had adequate stromal thickness, and we implanted cells. Corneal thickness too much too thin, and then we implanted human corneal laminas of 100 microns with or without stem cells. And then we demonstrated in these three groups that in the first group, human mesenchymal cells, autologous in this case, were able to proliferate, creating 16 microns of corneal thickness every 6 months. Okay. In the second group, in which we implanted only stromal, a cellular stroma with cells, that the repopulated new stroma was populated with a lot of cells, so cells multiplied in an enormous way, and this biological activation of the cells was really outstanding, and led to a much better cornea. Not only that, the corneal opacities that in some of these corneas happen to be were shown to be disappearing or declining and fading because of the phagocytic activity of the implanted cells. This was really the demonstration that what we observed in the experimental animal was true. The stem cells can regenerate corneal tissue transplant and can even eliminate corneal scars. But the surprise was when using only acellular corneal laminas, that means with no cells and no stem cells, that a similar effect was found. So it was found that there was a tremendous biological activation of the local cells. These local cells could reactivate the phagocytic activity as well, and the opacities of the cornea faded as well. So that made a question mark over whether the stem cells were or not necessary, because it seems that the signaling to bring the cells to be activated is
the keratocytes.
That's right. So this is a totally new concept, and really makes this to be available easily, because porcine collagen is present obviously in not limited amounts of as it happens with the human cornea, but also we could have this procedure not to be a graft, because a cellular collagen simply is collagen. It's not a graft, and even that is other animal, this indeed proven because of the heart surgery, and because many of the fashion which porcine collagen is used, that is feasible and is working well. So we have with these 3 studies published in about 8 papers already, that we have opened a new perspective. We can substitute the corneal stroma by non-human corneal stroma. We can substitute the corneal stroma by laminas of human origin. We can add cells, and these cells activate the cornea which are implanted, probably in a way that is complementary to the one that is performed when you implant only the laminas. And finally, that only cells injected in corneas that has no corneal stroma thinning problems can produce collagen, and can substitute probably the cells that are diseased in the pathological conditions of many corneal dystrophies by new cells that obviously are from the same patient, and theoretically with the same genetic burden, but in the future will be from perfect donors that will not have this genetic burden, and which makes much more sense. At the moment, we're using autologous mesenchymal cells because for ethical purposes we are not authorized to use cells from a human origin, but not from the same autologous origin. But I'm totally convinced that in the future we shall have banks of cells that are proven to be perfect in terms of genetical burden in unlimited ways, in limited amount, and capable to be injected easily and with a minimal invasive surgery in the patients affected by corneal dystrophies, corneal opacities, and probably of the types of corneal diseases.
Which stem cells are showing more promising effect on human cornea? What are your thoughts about that? Because there are many kind of cells, and also in your book, Regeneration of the Cornea, you also described all kind of stem cells. So which stem cells are showing more promising effect for corneal tissue particularly?
Probably to understand, we have different ways to skin the cat. Probably all of them work well. Probably all of them work similarly. The issue is which are less obtained in a less invasive way, in more amount and with less problems, with less ethical problems. For instance, bone marrow cells are easy to get, but they are invasive. You need to perforate the bone, and it's more traumatic. Not to talk about the umbilical cells, which have some ethical issues. I think that the most ubiquitous, the most frequent, and the more accessible are those coming from the fat for different reasons. First, because they have been used in many other studies in the human being. Second, because the fat is present in every single patient, and you don't need more than a limited liposuction, which is very safe, very cheap, and is very conservative to perform. And finally, because you obtain millions of cells. In 100 cc's, you can get the cells that you need, because these cells are identified and later on expanded, and you can obtain 9 or 10 millions of cells in a person that is even thin and that doesn't have a lot of fat in a very adequate and very reproducible way. So in my opinion, mesenchymal stem cells of adipose origin are easy to get, are cheap, are cost effective, and can be manipulated with easiness, and you have access to them worldwide. While other cells have other types of problems, but most probably the potential to create a benefit in the cornea is the same in all of them.
Yeah, so the next question is just, so you already explained about what is the difference between decellularized laminas and recellularized laminas. But in order to make it more easy to understand, what can you say briefly about, so in order for people to understand, for doctors, especially young doctors, what is the decellularized lamina which we're implanting in one of the groups, and how the lamina becomes then recellularized again?
Yeah, this question is difficult to answer because we have one evidence. Both acellular and recellularized laminas do stimulate the cornea affected by corneal dystrophy. Obviously, it makes sense that the number of cells that you are obtaining by putting laminas with cells is going to be larger, and is larger. So the number of cells is better. We did studies on densitometry, now in the process of being published in Cornea, in which densitometry demonstrates that those laminas with cells gets transparent faster. That makes sense, because they are healthy cells. Obviously, they have the burden of the mesenchymal cells of the cornea, but probably it will take time for them to become apoptotic and to make the cellular stroma to be hypocellular again. So with this in mind, implanting in corneas that have inadequate thickness and inadequate population of keratocytes to plant the laminas with cells is the right way to go. But now imagine that you have a thin cornea or a diseased cornea in which you have not an abnormal level of keratocytes, for instance, following corneal trauma. What you need is to replace a stroma, and it might be that only replacing a cellular stroma is enough because the rest of the stroma of this patient is healthy. That is another possibility. Another example could be corneal dystrophies. Imagine that you have a macular dystrophy in which you have a moderate opacity. In advanced opacities, I think that probably we have a different problem. Injecting the cells, you will have part of these opacities to disappear, to fade, and that will reestablish the corneal transparency in these patients. And finally, if you have a cornea like in keratoconus, in which you have a thin cornea and very poor cellularity, to implant laminas with cells will make sense. So that we have different scenarios, and we use different tools. Probably in this type of surgery, we shall use different biological tools to make our surgery to be successful.
So this was actually also my next question, which you answered already when I wanted to ask, do you think that for the future, these therapies which we applied for 3 groups, because we applied different therapies for each group, will be also performed for patients based on their basically status and cornea? So this will be like 3 separate methods. Yeah, correct. This will be new corneal stromal surgery. Corneal stromal regeneration surgery has emerged, is now there, is existing, and we're practicing it. Now, with a passive permission, you can implant the cells in patients. We are using this in the studies in Spain at this moment, and this is a way to manipulate what is 99% of the corneal thickness, which is the corneal stroma. Corneal stroma, which is affected in corneal stromal dystrophies, but also in many other diseases in which we are involved
the stroma in facial keratitis, especially trauma, and this type of problems in which you really have a good ocular surface, adequate endothelium, but the problem is the corneal stroma. This is the way in which corneal stroma disease will be approached, and I'm sure that the association of this surgery to ocular surface regeneration therapy and corneal endothelium regeneration therapy will make a tremendous impact in the future of our surgery as well. Not only that, I really believe that an organoid, corneal organoid, needs to be made up. We have applied for a grant to the European Commission to study in a multi-national group, including a British group, an Italian, and we in Spain, to develop an organoid in which we could have all the layers of the cornea capable to be transplanted, in which we could have whole cornea transplanted without any immunogenicity. And obviously, this is a dream, but it's a dream that is affordable in the coming 10 to 14 years if we have this grant. This is our bet, and this is our future project that is already applied, and I hope that will be successful in the application.
This is so exciting. I think it's really a new revolutionary era of cell therapy for not only for keratoconus actually, but for all corneal disorders, which leads to structural changes and scar formations.
Correct.
So in the article, there was also pointed that keratocytes, they were mostly gathered in the posterior stroma, because you evaluated the stroma, anterior, mid, and posterior stroma after doing this cell therapy, and the posterior stroma showed the highest density. So what do you think the reason of that? Why posterior stroma? Is it because of the method of the injection or the morphology, or?
No, in my opinion, it's because the approach of implanting the cells at the midway between the surface and the endothelium. So as we use keratoconic corneas, corneas have an irregular surface and regular stroma. So what we took is the thinnest part of the stroma, and we implanted cells in 50% of this thickness, including the epithelium. That makes the implantation to happen in the posterior stroma, obviously, and this posterior stroma benefits from the implantation, benefits from the repopulation much more. We have studies up to 3 years, which are the ones that we have published, and this increase in the posterior cellularity is indeed being kept over time. Not to talk about the anterior cellularity, which is very much increased and is overwhelmingly increased over the previous presurgical stage. But the meaning of this repopulated posterior stroma is, for us, still unknown. There should be a reason for that, probably related to the experience. But what we observe is that this characteristical distribution is kept over time. And in my opinion, we have the demonstration that we have such a high population of keratocytes that they can migrate not only to the places in which they are more needed, which are the anterior corneal stroma layers, but to the posterior surface as well, from which, in my opinion, they constitute a reserve. It's a population reserve for the superficial keratocytes. In my opinion, this is stratification of the cells has a meaning, and probably the meaning is they are given the second line of action just to substitute the ones that are more superficial if the disease reappears.
So let's go to the third part, because you covered perfectly the first and second part already. So what is your target? I mean, what is our target for the future? You covered already briefly what is your dream now to achieve with a cell therapy for keratoconus patients. But do you think that stem cells implantation therapy can also be used in advanced cases with Hydrops? For example, when cornea is partially damaged already?
Clearly, yes. Have an acute stage in which you have to solve the problem of the breakdown of the descending membrane. But once that it is solved, what it remains is a scar. This scar makes an important problem for deep anterior laminar graft, because deep anterior laminar graft basically is not possible to be practiced in these places because macro perforations happen in most of them. Only leaving part of the posterior stroma, you can do a deep anterior laminar graft, but at the cost of delaying a lot the visual recovery. So these cases should be perfect for this experience, because these corneas are athatic, these corneas are depopulated, they are very much disease, and to implant a thicker lamina, probably customized to the shape, could replace not only the thickness but also the optical function of the cornea. We have a study published already with an Iranian group of Dr. Jadidi, in which we have demonstrated that with 3D printing, we can customize corneal tissue. You can customize corneal tissue. Imagine that we want to provide, without these laminas, the new shape of the cornea, and obviously we provide thickness with the shape. The shape will be kept by the recipient cornea, because recipient cornea is hyperelastic and diseased. So, in my opinion, this is an extra indication, because if we implant in the mid-stroma of these patients affected by corneal hydrops, lamina thick enough and in part customized with cells, this repopulate the cornea, which is the profit from keratocytes after corneal hydrops, replaces the stroma and replaces the shape. And most probably, and this is obviously the main issue behind, replaces this tissue in volume and in geometry, replacing vision as well, improving vision. This is the way in which I think that we shall manipulate the stroma. With 3D and 5D printing, human cornea will not be used, will be used porcine stroma, becoming a cellular. In this way, we shall have not a heterogenic implant, and with no risk of immune rejection, with no risk of immune and inflammatory reaction, and replacing the shape as well. This replacement theoretically is possible, but if we consider that we have already worked on this topic with a group of Mario Nubile and Mastro Pasqua in Italy, we have customized in a human eye cadaver model the corneas coming from smile surgery, making the shape of the cornea to be better. So preliminarily in the human, this is demonstrated in cadaver eyes, but I'm sure that this customization of the shape, playing with the shape and the volume, will make the perfect matching with abnormal distorted corneas like in keratoconus, avoiding completely corneal graft and the consequences of it.
And next question is like, do you think that the treatment of this cell therapy for not only for keratoconus but any corneal disorders in patients can be repeated?
Of course, yes. In corneal stroma, we have already mentioned that, but a human corneal endothelium might be replaced by endothelium that has been grown in an endothelial culture, but all the type of cells, mesenchymal cells, can really replace this endothelium as well. We have published it in Investigational Ophthalmology and Visual Science in a paper in which we demonstrated that the mesothelial cells, mesothelial, not endothelial cells, have the same characteristics as the endothelial cells and could be used as to replace endothelial cells. This opens a huge area of research. We're on top of that because, as you know, human endothelial cells are very difficult to make them to proliferate in vitro, and in vivo do not proliferate. The mesothelial cells, they do proliferate in vitro, and they are kept in vivo, and they preserve the characteristics of the mesothelium, making the cornea to be with level of hydration and is adequate, and this is a huge promise for the future. For the ocular surface, mesenchymal stem cells have been used successfully, and the only one problem is still how to keep the cells in the cornea in the long term is the problem, because the cornea becomes transparent. These layers of cells are effective in terms of providing the help and the transparency of the cornea in these affected eyes, Steven Johnson. But the problem is that they don't have any niche in which they can be kept to proliferate. And the main investigations are exactly that ones, how to make a reservoir of the cells that are implanted in the ocular surface for the purpose of keeping in the long term this type of ocular surface surgery active and effective.
Mm-hmm. And how long we have to wait before we repeat the procedure again?
The procedure can be repeated anytime because it is minimally invasive. And if you have, imagine that one lamina is not working well, you can explant the lamina and to make a new one available. It's not a single surgery capability. We can have the capabilities to repeat the surgery, substituting the layer or adding more tissue to the cornea as necessary. accomplishing the production of cells in a high volume and not in the limited amount of volume that we can obtain now from human origin will be much better.
And what will still need to overcome now for the future? You already talked about the future, what you're expecting, but at the moment, in the current stage, in order to go to the next step and to go further, what is your challenge at the moment?
The challenge of this surgery is the nerves, So, the nerves are necessary for the normal corneal trophism, and to keep the nerves is a mandatory issue. Any cornea with no innervation will fail, and will fail whatever we do, and corneal stroma could have a role and could be successful in the short term, but will not be in the long term if the nerves are not regenerated. Today, we don't have, in cases like herpetic keratitis and other types of diseases in which the trigeminal nerve is cut or destroyed, the capability to make the sensitivity of the cornea to be replaced. But we need substances, molecules capable to stimulate the nerves to grow, and this is the one limitation and the one progress that we have to make about these treatments, modalities, and also especially in the organ, how we can substitute the nerves and how can stimulate the nerves to grow into this cornea in order to maintain the biological support and the biological integrity that we can give the stromal regeneration.
Perfect. I think we covered all my questions.
Okay.
Thank you very much. Have a great day.
Good day. Bye-bye.
Bye.
Thank you.
Bye.